So the next presenter is going to be Dr. Charles Carpati. He's the clinical chief of critical care medicine at Lenox Hill Hospital. And he's an assistant professor of medicine of Hofstra and Northwell. He has more than 36 years of experience in critical care and dealing with the virus that obviously was overwhelming in this country and the world several decades ago, the HIV. He was in one of the main hospitals taking care of these patients. Dr. Carpati is going to present to us the New York City Experience. Dr. Carpati.
Good morning.
Good morning.
Can you hear me?
Yes.
Very good. Okay, so I'm going to shift a little bit towards what we had here in New York City. And this picture reminds me of the human cost of what we've been facing for the last couple of months. So this is the publication from a very important epidemiologic study just issued from Wuhan. And it points to the period and government interventions in terms of the number of cases that were materializing in the city. And I just want to point out that they divided their pandemic experience into 5 periods. And really, although this is a busy slide, we'll focus here on the 3rd phase where the lockdown orders were really put into place as the case number exceeded about 200 to 300 per day. So this is the time in Wuhan when the city was cordoned off and social activities such as concerts and meetings were curtailed. In New York City, we didn't really do this until March 23rd, and you can see that this was a time when cases per day exceeded about 2,000. And this may be part of the reason why ultimately our experience may not have been so successful in terms of mitigating morbidities and mortalities. And you can see that this translated into further hospitalizations and deaths. So ultimately, our experience in numbers was not as good as those quoted in Asia. And this is data from May 22nd. It's pretty much panned out into this month, but our mortality is about, our case fatality rate really is about 8%. And we all know that the older the patients were, the more susceptible they were both to contracting the virus and in terms of therefore getting hospitalized, and the difference magnified age-related in terms of mortality. In terms of gender, we had a similar experience to other parts of the world where males seem to be more susceptible, and that was magnified as well in terms of hospitalizations and as well in terms of mortality. Now, New York is a very diverse population in terms of national origin and in terms of ethnicity. And so it's really one of the only cities in the world where these disparities are reported in terms of what's going on with the pandemic. And you can see that Latinos and African Americans were disproportionately affected, and Asians the least, with whites somewhere in the middle here. And this as well was reflected in the rates of hospitalizations, and interestingly, in the deaths, the Hispanic Latino population, although it's a very small difference, ended up exceeding the death rate in African Americans, while Asians and whites were much less affected in mortality. Now, this likely reflects the socioeconomic differences in these populations, so that you can correlate by postal code in New York what the areas of the city are with worse socioeconomic conditions, and these also correlated with the rate of contracting the virus, as well as the death rate and the hospitalization rate. So there may be genetic reasons why the virus may have affected certain ethnicities more proportionately, but this likely reflects a lot of socioeconomic impacts. And this is another slide looking at this a little bit differently in terms of income, and higher incomes tended to be affected less by COVID-19. And this is a map of New York City, which consists of 5 areas or boroughs. This is Manhattan, and lighter colors suggest less affliction. Some of this may reflect the fact that a lot of New York City residents left town when the virus escalated. And more people in Manhattan probably had other places that they could go to. Nonetheless, in terms of prevalence and in terms of mortality, the boroughs with the greatest degree of poverty were the most afflicted, and that would be the Bronx, parts of Queens, and Brooklyn. Here, interestingly, the Rockaways, which is a beach community, and Staten Island are more island communities where, independent of socioeconomics, people may have just been more together socially, and thus allowed the virus to proliferate among citizens. Interestingly, Staten Island, being isolated, had less mortality than the Rockaways. And we know that the virus is more dangerous in patients who have underlying comorbidities, so that we can see that almost regardless of age, 75 to 80% of the mortality happened in patients who had underlying illnesses. And as we know, those included, but were not limited to, obesity, hypertension, diabetes, lung and kidney diseases, and underlying cancers. Now, as the viral cases abated, the ICU population abated more slowly. So this shows that a lot of patients were kept alive, frequently by mechanical ventilation, and many of those patients lingered and may well contribute to the ultimate higher levels of mortality that we will probably get when we get the final numbers as the pandemic essentially finishes, or at least the first wave of the pandemic finishes. Now, interestingly, we've started about a month ago now to get more in the way of antibody data from our population. And if you compare New York City here, this being New York State, but New York City prevalence of antibodies to the prevalence of antibodies in other cities, here in New York City has about 20% of the population. Now, this is incomplete data, so it's a little bit early to get final numbers. But New York City is so far ahead, it just suggests that the socioeconomic and distribution characteristics of our population led to very easy spread of the virus, and may get back to that original slide where our lockdown measures happened rather late compared to, say, Wuhan. And the distribution of antibody positivity mimics the socioeconomic and geographic slides that I had a little while ago, in that the Bronx here has 27% of the population antibody positive. There's a little bit closer clustering in terms of Queens, Manhattan, and Brooklyn, but Manhattan has the least. And in terms of ethnic distribution, the Latino population far exceeded all the other populations, followed by the African American, Asian, and white population. So I'd like to shift here from the demographics in New York to our clinical experience. And some of this stems from the fact that we have a number of major medical centers here in New York City, and we each had different approaches to the treatment of the victims of this pandemic. And some of this stems from the fact that although the Chinese experience has started publicizing their protocols early on in our experience, this information was fairly slow in coming officially, and we were left with trying to piece together various experiences, both published officially in journals and in other areas that were semi-official, say on the internet, and speaking to our colleagues in other countries, chiefly China. So our experience mimicked that in other hospitals, in that we went through a total of 18 algorithms, this being the first one in mid-March, where we didn't have remdesivir, and so we were left with hydrochloroquine as our first medication to be used in anybody presenting with this disease. And a lot of these patients also got azithromycin. The data on Kaletra had not come out yet, so based on the experience in Asia, we tried to give all our patients Kaletra, lopinavir, ritonavir, but we actually ran out of this fairly early. And we reserved anti-interleukin-6 therapy to the patients who were severely ill, and basically that meant on mechanical ventilation, either non-invasive or invasive. And we tried to support what we were doing by the indices of inflammation, ferritin, CRP, and D-dimer, and oxygenation. Now, the 18th version of this happened about less than 2 months later, where now remdesivir became more universally available, certainly not universally available, but concerns about hydroxychloroquine and cardiotoxicity came to the fore, although this remains controversial, as noted by Dr. Hung. It was our impression that we should try and mitigate the cytokine storm earlier in the disease. Not everybody agrees with this, and the studies remain to be finalized. So we started to give tocilizumab earlier in the disease as the patients were starting to get more hypoxic. And we reserved steroids for patients who had progressive lung disease, as outlined before by the previous speakers. But this essentially has no good data. So we've been through 18 algorithms, as has the rest of what our universe is, without having any great data as to what we're doing. The best data being that for remdesivir, but even that is questionable in terms of whether it's useful later in the disease, and the mortality data has yet to achieve statistical significance. So in the absence of true guidance from any real central body, the guidelines that have been issued have appropriately stated that for every stage of treating this disease and its sequelae, the data is just poor. Our experience and that of the hospitals in the area that we've talked to is fairly uniform in terms of the problems that we have faced. The fear of the staff appropriately in contracting the disease from aerosolization, despite the usefulness of good personal protective equipment, has led to our using a less than optimal humidification on our mechanical ventilation, and potentially causing less mobility of secretions and potentially leading to worse outcomes in these patients. We have done a lot of effort to improve that humidification, but I wouldn't say that yet we have achieved optimization because the data isn't there. And we've still done a good job in protecting our staff. The same thing applies to the aerosolization of bronchodilators, mucolytics, and resulting aerosolization from use of high-flow nasal cannula and non-invasive ventilation in non-negative pressure settings. So we've been very concerned about that. Now, this science fiction-looking slide shows the heroic efforts of our engineers in actually creating a whole floor of negative pressure rooms to mitigate against this effect, benefiting our patients. The high need for oxygen here has led to more concern about oxygen toxicity without great ways of mitigating against that, except for assiduous attention to trying to minimize oxygen levels. The whole concern about self-induced lung injury versus ventilator-induced lung injury has led to this question about, is intubation harmful for some of these patients versus how long do you wait and have them with high works of breathing before you do intubate these patients? This is a very critical question for the future. Does anticoagulation mitigate against further respiratory damage? Some of this is suggested by autopsy data, but still up in the air. And ultimately, what will happen in survivors with poor residual lung function? This remains to be seen. Some of these patients received steroids. Renal issues, the high degree of renal injury. This is a study from the Northwell system. 36% of hospitalized patients had some degree of renal injury. 31% of those had stage 3 acute kidney injury. So the need for renal replacement therapy was impressive. 54% of the patients who had acute kidney injury in their series required hemodialysis. 24% got continuous renal replacement therapy, and 21% had a combination of the two. Here at Lenox Hill, we had 135 patient days of continuous renal replacement therapy in April and 81 patient days of aquapheresis as we were trying to use up to at most 10 machines for continuous renal replacement therapy. We faced, as did the whole world, the hematologic questions of the associated hypercoagulable state. What do you do with the critically ill in terms of prophylaxing them versus actively treating them to try to mitigate the associated organ failures that might have been occurring from brain to lung to kidney, etc. So this was our algorithm, which utilized mostly Lovenox or low molecular weight heparin in our patients, but then considered extending that therapy should they be what we thought at risk for thromboembolic disease by their improved score, their age, and elevations of the D-dimer, the levels of which are yet to be elucidated in order to make these kinds of decisions. This I downloaded from the internet. So this is the Mount Sinai anticoagulation algorithm, where they were much more aggressive. If you were admitted to an ICU, you got fully anticoagulated with unfractionated heparin, low molecular weight heparin, and even consideration of TPA. And we have yet to see good data to see whether this was the right approach or not. In endocrinology, we saw a fair amount of DKA and hyperosmolar states in these patients. In order to limit nursing exposure, we adapted, instead of insulin drips, a Lispro protocol that required a visit every 2 hours instead of every 1 hour. Was this as effective? We think it was, but was the decrease in patient exposure somewhat problematic? That has yet to be worked out. We don't understand fully the severe hypertriglyceridemia that you see in these patients. The CNS issues are getting more play, as Dr. Ortiz started this symposium by stating. So we've seen severe delirium up to encephalitis, necrotizing encephalopathy, seizures, stroke somewhat separate. Some of these diseases are clearly going to be chronic, and we don't understand yet the full time course. Will they in fact become dormant and then reactivate in the future? We've discharged a fair number of patients, fortunately. Many of them need home oxygen and pulmonary rehab. If we did feel they were at risk for thrombosis, why would that change when they leave the hospital necessarily? So we have yet to work out how long we might want to prophylax those patients. Long-term dialysis and renal recovery has yet to be worked out. The CNS issues, as I mentioned. The interpretation of antibody testing. How well does this confer immunity to reinfection? And we're starting to see readmissions of the COVID population. So understanding more than the acute impact, the chronic impact and associated costs to the medical system. And finally, ethical issues. Some of these anticipated issues never materialized. And my understanding in New York City is that these were few and far between. But we did have plans in terms of ventilator rationing for putting multiple patients on ventilators. When we were running out of medications, we had plans for alternate approaches, but this was essentially medication rationing. This is just a snapshot of what we were doing or requiring daily in the ICU population, and comparing March and April to 6 months in 2019. And you can see that for these critical medications, fentanyl, propofol, dexmedetomidine, norepinephrine, cisatracurium, the needs expanded by multiples that were in fact mind-boggling. And although we did not experience shortages for long, other hospital systems did in fact report these shortages and have to move to alternate ways of sedating or supporting their patients. Initiation of dialysis. We came close to having to ration dialysis, and in a sense, sometimes we did. Continuous renal replacement therapy wasn't fully continuous all the time, so we might have alternated days on some patients. That was a rare occurrence, but it did happen. The whole question of CPR, where certainly in New York, we're not allowed to forego CPR without the family's instructions. Some physician papers did come out advocating this. We never got to this in our hospital system, as far as I know, or any other hospital system. But the benefits of CPR versus the risks to staff were starting to be discussed, and ultimately need to be fully discussed in greater forums, likely nationally and maybe worldwide. The whole question of immunity passports for patients who have experienced COVID and now have antibodies is going to be again, a worldwide phenomenon in terms of creating potentially two classes of people and limiting the mobility of one class of people. And finally, we've been inundated with data for this disease, much of it poor. And just yesterday, Lancet had to retract a big article on hydroxychloroquine. A lot of the data in major medical journals is based on very few patients and develops authoritative conclusions. And I'm sure that this is going to come back to haunt us. So I think the publishing community, in the interest of expeditiousness, has pushed out a lot of these articles, but they're going to come back to haunt us. Despite all this, the good news is that we've had a tremendous amount of teamwork. I think the first two speakers showed us what happened in China and how successful that was. I think that one of the things that's benefited our patients is just having the wonderful teams that we had, from the physicians to our engineers who did superhuman construction work, to our leadership that supported those efforts and worked to see how they could improve delivery of care, to our nurses who were superhuman, our respiratory therapists who were superhuman. And ultimately, it gets back to this. I think I've never been prouder to be a healthcare professional. This picture shows one hand reaching out to a patient. In the best circumstances, it would have shown 50.
Thank you so much, Dr. Carpati, for the very comprehensive presentation and very clear summarizing all the challenges and difficulties of managing this type of patients. Again, thank you for the presentation and being part of this symposium. We're running late on time, so we will not have time for questions right now. We're gonna move forward for the next presenter. Is Brian Levinsky. He's a critical care paramedic who has worked in EMS over the past 19 years, over 15 years of which have been with Northwell Health. Brian oversees training and quality for the Northwell Health Center for Emergency Medical Services and was recently honored as one of the American Ambulance Association's inaugural class of 40 under 40 in mobile healthcare. Great to have you, Brian. He's gonna talk to us about EMS is the first responder.
Hi, good morning. Thank you for having me here today, and thank you for everyone joining us, and particularly thank you to Lenox Hill Neurosurgery for giving me this opportunity. So we're going to talk about the role EMS played, particularly in New York City and Long Island. Just the disclosures that any of the opinions I express are not the opinions of my employers or any committees that I serve on, and I have no financial disclosures. A little bit about Northwell Health and our Center for EMS. We operate in all of New York City and Long Island. We provide emergency care and specialty care transport services throughout this area. So this includes 911 services with the FDNY New York City system, and we have public-private partnerships with some of the villages in Long Island. Our communication center handles 911 calls from our public-private partnerships. We also get direct dial emergency requests, and we do interfacility work, and they handle the transfers and arranging the transports. Northwell, we provide, like I said, we have specialty care and critical care interfacility transport. We do ground ambulance, and we have our own air medical division, Sky Health. So in 2019, just some numbers, we did 494 transports by air and 126,000 transports by ground. So back in January, we actually started surveilling for patients with potential symptoms of COVID-19. We used, it's called the Emergency Infectious Disease Surveillance Tool. It's actually part of our dispatch system. And we started asking questions about the travel history and the symptoms originally. Positive screenings were used to alert the responders to utilize enhanced PPE so that when they showed up, they were wearing the PPE, even though there wasn't a reported COVID case yet in New York. We also alerted the receiving facilities, and these questions had to evolve, obviously, as the disease became more widespread. Originally, we were asking just about China. Then as it moved throughout the world, we added other countries in Asia, and then we really stopped asking about travel history. We were asking more just about the symptoms, the fever, cough, shortness of breath. And then we started, as it became widespread in New York, really not just the symptoms, but also did you have close contact with someone who was a confirmed case, or if it was a clinician calling for a transfer, or you've seen the doctor, did the doctor suspect it, then we're just assuming you had it. We're not worried about the positive test, we just assumed. So PPE was a big issue everywhere. Our guidelines actually really evolved throughout this whole thing. This slideshow really shows our final PPE guidelines. Is actually what we are still following, even though the pandemic has really calmed down and we're seeing less and less cases. So early on, we had mask mandates in the buildings that house our communication center to reduce the risk of the virus spreading amongst our staff. So this was actually in place early on before the hospital started actually wearing masks. Because our communication center is a small area where people are close in there, it's answering phones, the risk of spreading in there was great, and it's a skilled workforce. They're specially trained on how to do these, take emergency calls. So if one person got it, the chance of wiping out half of the workforce being out on leave would really have impacted us. And this worked because we did have people who did contract COVID-19 in the outside of work, and it didn't spread. So we did have our concerns of shortages just like everyone else. We did initially restrict when we would wear an N95 to just aerosol generating procedures, but this really created a lot of stress and anxiety amongst our staff. So we really did ease up on that. Even though we still weren't 100% positive that there would be a supply chain, our staff is very important to us. So we did implement reuse guidelines, strict inventory monitoring. We tracked every day our burn rate. And we started really wearing PPE for every patient encounter. Even if the screenings initially were negative, we still wore the gown, the goggles, gloves, and we wore just a face mask And if it was a positive screening, we wore the N95. We also had the head covers and booties. They weren't recommended by the CDC, but it made our employees feel more comfortable. So we gave it to them as an option if they wanted to wear it, because like I said, their safety and their concerns and their mental well-being was very important to us. You know, it's not just about them, but they were very concerned about bringing this home to their families. So just like the hospitals, we saw a really sharp increase in patient volume from the end of March to the beginning of April. So you can see on this chart, really around the end of March is where we really saw that real spike. March 30th was actually our highest call volume day. It was also the highest call volume for the entire New York City 911 system. They saw over 6,500 responses citywide. And that day, Northwell Health's ambulances responded to a total of 760 calls throughout New York City and Long Island. This increase in responses, combined with increases in turnaround times at the receiving hospitals, put a tremendous pressure on the EMS system, and it also put a strain on the physical and emotional well-being of our team. But as you can see, this chart kind of has this torsades look to it. From the second week of April to today, we have seen a significant decrease in EMS call volume, which is consistent throughout the region. And while this break for our team from the heavy call volume a few weeks ago was certainly well deserved, the sustained decrease in volume places a financial strain on EMS, and it's actually starting to become a concern nationally, because most of EMS agencies, through the hospital-based, we get paid and financed by insurance reimbursement. So if we're not transporting patients, we're not receiving funding, we don't receive tax dollars to fund our services like a municipal service. And you see at our peak, we were about 69% greater than a normal, versus right now we're 37.5% less than normal. So in addition to the increased emergency call volume, we also had to assist some of our overwhelmed facilities with load balancing, particularly in and around Queens. As Dr. Carpati's maps showed earlier, there were pockets of Queens which had extremely high number of patients, and we have hospitals in the Northwell Health System in those areas, particularly Forest Hills and LIJ Valley Stream. So overall, 810 patients were moved between the system hospitals, 241 of which were transported on mechanical ventilators. And we transport these patients without respiratory or doctors or nurses. Our paramedics are trained to maintain a patient on a mechanical ventilator. But this was a massive undertaking because we were doing this, started around March 21st. So that's right when we were hitting this peak of March 30th coming up. And so our ambulances were responding to 911 calls. So we actually did have to rely on some of our local EMS agencies, some of our commercial partners, and the FEMA task force that was sent here helped us out as well. And we moved these patients by ground and air. Yes, we did transport COVID patients in the helicopter. But so we had to also look at ways to ease this impact of increased call volume on the EMS system and the hospitals. So one of the ways that we're trying to do this is we worked with the New York City Fire Department and the 911 system to create a pilot program of alternative pathways for the emergency callers. Several of the large health systems in New York City are participating in this pilot project. It's actually still going on. So the way it worked for us, at least, was that callers who met certain criteria, which was established by the International Academies of Emergency Dispatch, instead of automatically dispatching an ambulance to them, which is the norm, we had some alternative pathways, such as we arranged telehealth visits with the physician. We made appointments at a local urgent care, or we actually have nurses who are specially trained to take emergency dispatch calls, and they actually have another set of questions that they ask to even further identify risks, and they provide self-care instructions to the patients. And we did follow up on these patients as well. And this project is, it's going. It's a little culture change for the 911 callers, so it's got some challenges. And we'll talk about a little bit of that later on. So the cardiac arrests, though, were a huge issue, and Dr. Carpati mentioned that as well. We saw a 200% increase in cardiac arrests from the same time period in 2019. So it was about 682 cardiac arrests in between March 1st and April 20th. We continue to actually see this higher than normal rate of cardiac arrest, despite the fact that the overall call volume is being lower than normal. And this really posed a challenge, not only because of the increased demands on the EMS system, but also because of the high number of aerosol generating procedures that go along with resuscitation. So to ensure the safety of the responders, protocol changes were put in place. So some of these changes were limiting the number of responders on the scene. So we used mechanical CPR devices. So in New York City, the standard response for cardiac arrest is we send 2 ambulances, a basic life support with 2 EMTs, an advanced life support with 2 paramedics. We send an FDNY engine company, which can have up to 5 paramedics, and an EMS supervisor. And one of the reasons for this many responders is to really ensure that high quality CPR is being delivered using the AHA recommendations of rotating every couple of minutes. So mechanical CPR devices help reduce this need. Another concern was the airways. So having someone squeezing a bag valve mask in an open airway potentially exposes them to the aerosolized virus. So we were actually using simple oral airways with some high concentration oxygen through a non-rebreather mask. And then we covered the mask with a face mask to help reduce the risk. We also put filters on the BVMs when we used them with advanced airways. And as far as advanced airways, we really stopped intubating and went to alternative airways, supraglottic airways, instead of direct laryngoscopy. We didn't have, I know that the hospitals really came up, innovated a lot. I saw these, the plastic shields, boxes that were made. I saw hospitals using PAPRs. We really don't have those options to carry a giant plastic box in every ambulance that we can put down. Video laryngoscopes was something that was also beneficial in the hospitals. We really don't have that as a common thing in EMS yet. We are actually considering it. And we perform our intubations by lying down on the floor. So this is really intubation was a huge concern for us because we're really in the patient's face. The next 2 changes were really the controversial ones. And I think it's important to talk about it. There's some ethics concerns, and I'm going to spend a couple of minutes really talking about these 2. So initially, protocols were put into place not to transport patients without a return of spontaneous circulation to the hospital. So basically, we weren't going to do CPR in a moving ambulance and bring someone in cardiac arrest to a hospital. We would spend 20 minutes on scene attempting to resuscitate them. We go through the full ACLS algorithm. If there was no change, we would terminate resuscitation. This is actually kind of common to what we do in New York City, except normally there's a little bit of provider discretion to continue these efforts and transport without a pulse. And also we normally would have to consult with a medical control physician before we stop CPR. Now there was a hard stop at 20 minutes. So it did make the local and national news. Some of the headlines were a little off from what I just explained, and I think that caused a little anxiety amongst some of the population. My mother called me. She was concerned that if something happened to her or my dad, we wouldn't treat them. And I had to explain to them that what we do is we do the entire ACLS algorithm in the home. And the reality is that if after 20 minutes of ACLS, we continue on and we do get a return of circulation, the quality of life is not necessarily going to be the greatest as well. So it actually sometimes in the patient's best interest not to continue. And that wasn't the most controversial. It was really the next one that really caused a lot of controversy in the New York City region. And that was a protocol put out by the state not to initiate resuscitation on certain patients. And this was beyond, normally we don't, if you have advanced directives, obvious deaths, dependent lividity, rigor mortis, obvious mortal injuries, but this went much further than that. So on April 17th, New York State issued a statewide protocol for not initiating a resuscitation. It was a crisis standard. It stated that for adult patients who had an arrest not witnessed by EMS and the AED showed no shock advised or asystole was seen on a cardiac monitor, resuscitation was not to be initiated. As the memo stated, there is published evidence that support this. To quote Wikipedia, citation needed, there really wasn't any there. And part of my role during this pandemic was actually to be the one voice communicating information to our entire team. So I knew that once this was sent to our staff, it would raise questions. We actually communicate via a closed social media type platform, and the staff interacts just like in social media. So the tons of questions and comments. So I really made sure I did my research to see what this widely published evidence was. And I did find some stuff, and I'm going to share that. So there was a 2008 study in Helsinki that found that the 30-day survival rate after an unwitnessed arrest was 0.5%. All survivors in this group were either hypothermic or were victims of a near drowning. And the authors concluded that resuscitation should be withheld in cases of unwitnessed asystole, excluding cases of hypothermia and near drowning. And it showed that conversion of asystole into a shockable rhythm during resuscitation is also only associated with a short-term benefit. And I forgot to point out, so this was really, it was asystole, PEA, or if a basic life support had an AED and it showed no shock of eyes, that's when we didn't initiate resuscitation. VFib, VTAC, shockable rhythm on an AED, we went through the usual process. So other things I found, the European Resuscitation Council Guidelines for Resuscitation from 2015 recommended that healthcare professionals consider withholding or withdrawing CPR in children and adults when asystole for more than 20 minutes despite ongoing ALS in the absence of reversible cause. And they also included a statement that, and I think this is a very powerful statement to consider when you're thinking about ethics, is that CPR that has no chance of success in terms of survival or acceptable quality of life is pointless and may violate the right for mercy and dignity in the face of death. The National Association of EMS Physicians published a position statement in 2011 about termination of resuscitation and when to consider it. And it talked about, just similar to what we just looked at, that algorithm, it was not witnessed by EMS, no shockable rhythm identified by an AED or cardiac monitor, and no return of spontaneous circulation prior to EMS transport. They didn't give a specific time of resuscitation in this position statement, really citing the need that there needs to be further research out of hospital to really determine when is the optimal time to pronounce. So 2014, there was a study from Australia that looked at cardiac arrests that were asystole and PEA for over a 10-year period from 2003 to 2013. This one showed that rhythms of asystole, patients with initial rhythm of asystole had a 1.1% survival rate to discharge. And 12 months after discharge, 2/3 of this 1.1% were either deceased in a vegetative state or had a lower severe disability. This the paper also recommended adherence to the strict guidelines from that Helsinki study that I first showed, stating that they may help to improve the success of resuscitation efforts in asystolic populations and reduce futile resuscitations in patients for whom there is little chance of survival to hospital discharge. The American College of Emergency Physicians has a policy on non-beneficial emergency medical interventions, which states, emergency physicians caring for patients in cardiac arrest who have no realistic likelihood of survival should consider withholding or discontinuing resuscitative efforts in both the pre-hospital and hospital settings. So there is this evidence, like they said in the memo, but despite this, it really wasn't well received by the public and some members of the EMS community. And a few days later, the front page of the New York Post was this, let them die. And later that day, the New York Post actually published on their website that New York scrapped the do not resuscitate order during the coronavirus pandemic. And the next day, the official memo was actually put out by the state. And it was really that the Department of Health commissioner said that these standards weren't necessary and that the protocol change was this protocol change was into place from the end of the 3rd to the beginning of the 4th week of April. So if we look at that volume chart from beginning of the slide, we're really at this, we're really at this lower period over here. So the question really remains, if this protocol was been better received if it was issued at the end of March when we were back over here, where we've seen tons of cardiac arrest, tons of call volume, versus when it was released down here, when we were already slowed down and it really wasn't overwhelming our system to respond to these cardiac arrests. There were some successful protocols put in place. There was this viral pandemic field triage protocol that was put out by New York State. This was released actually during the surge before we hit this peak call volume on March 30th. It outlined criteria for EMS crews to evaluate patients and recommend to the patient that they not be transported to a hospital. This helped reduce the burden on the hospitals. It also reduced the amount of PPE being consumed by EMS, as this assessment and going through this triage protocol could have been done by just one of the crew members, so not both people had to don their PPE. Patients not transported were given an information sheet with self-care directions, warning signs indicating a need to seek care again, and they were given the local COVID-19 hotline numbers to contact if they had any questions. One of the questions that comes up is, why is the patient's signature on the form that we were actually leaving behind? And that is because they were actually signing this, and then we were taking pictures with our electronic medical record system and capturing it that way, so that we left it behind, and it avoided the patients actually touching our iPads. So patients with flu-like symptoms, stable vital signs, no risk factors such as pregnancy, diabetes, cardiac or pulmonary disease, and no secondary medical conditions were advised to remain home. I did actually go back and look at this, and we did a quality review, and about 400 patients we left behind, and we had no negative outcomes, which was great. So we did make the clinical changes that we had. We limited aerosol generating procedures, like I said, BiPAP, CPAP, nebulizers, intubation. We used non-MIS producing nebulizers, which allowed us to actually continue delivering nebulizer treatments. We transported patients to the closest hospital to avoid overwhelming one particular hospital. And we tried prone positioning, which actually worked out very well. We did it into facility on our mechanical vent patients, including in the helicopter. And we did it on emergency patients with supplemental oxygen. And this worked out great. There were some concerns about how can we do CPR. There is research, and I'm just going to, for the sake of time, not go through too much, but there was an AHA Class 2B recommendation saying that you could do CPR in the prone position, and there was a study following up that also backed that statement. So really what it comes down to is, what are our new norms? Expanded PPE use is probably going to be something going on forever, though right now our concerns have been more about safety with some of the stuff that's going on in the community as far as civil disturbance, but we are still wearing masks, goggles, gowns on all our calls. We are continuing to use the non-MIS producing nebulizers, and we're actually considering just using those forever, because it's not just COVID that we're worried about. You know, the flu is bad too. We don't want to aerosolize pneumonia, anything. We need to have pandemic protocols in place. We shouldn't be working on creating them during this and then releasing them after we already need them. Termination of resuscitation guidelines. We need more studies on this. We need to really come up with a standard practice, really publicize with the community. Bacterial and viral filters we're going to continue using. Telehealth was a success, as well as the possibility of alternative destinations and treatment in place. The only problem with these three things really is that EMS is paid on a transportation model, so we don't receive reimbursement for any patient we don't transport. So if we arrange telehealth or we treat them in place, we actually don't get paid by the insurance companies. We kind of just take that as a loss. There actually was some talk about transport to alternative destinations, though it wasn't set up yet for this as well. There is a pilot project that was supposed to start now. It got pushed back because of COVID, but with CMS called ET3, which actually was a demonstration project for reimbursement through Medicare. So hopefully when that comes out, we'll see more. I do have references to some of the journal articles I talked about. So if anyone has any questions you want to, I can email them to you. You can just send me an email. That QR code will actually just open up your email to my email. And say thank you. And I'll turn you over to Dr. Ortiz.
That was great, Brian. Great comprehensive presentation, teaching us about all the efforts that you guys made during these challenging times. We don't have time for questions, but I have to thank you for the great presentation. I have to thank the entire team of EMS at Northwell Health, because not only during COVID times, but we interact with your team very frequently in the management of patients with strokes or brain hemorrhages, large tumors. And the entire team has great disposition, very active, very engaged, and always trying to make a big impact in every patient's life. And that's all we can ask for. And so it's tremendous effort, tremendous team. Congratulations.
Thank you for that.
Okay. So moving forward to the next presenter, we have Dr. Yves Duroseau. He is the current chair of the Department of Emergency Medicine at Lenox Hill Hospital. As chair, Dr. Duroseau provides overall leadership of the department with responsibility of strategic planning, development, clinical services, quality, professional performance, and medical education. Dr. Duroseau is also the co-chair of the Performance Improvement Coordinating Group for Lenox Hill Hospital. He's a tremendous leader, an amazing educator. All of his residents and students that spend time with him grow as clinicians by his lectures and example, and great friend. Yves is going to talk to us about emergency medicine at the epicenter of the epicenter. Yves.
Thank you very much. Thank you, Dr. Ortiz. Thank you to your team for putting such an amazing presentation together. So without further ado, I'm going to start. My talk is going to be truly about why New York City was the epicenter of the epicenter, and specifically what we did here at Northwell Health, what we did in our emergency department here at Lenox Hill, and a little bit about the disparities that Dr. Carpati spoke about, and finally some of the challenges that emergency medicine is going to face moving forward. So cases worldwide, this was updated June 3rd. We've seen 6 million.
If we are not seeing your slides. There we are.
Thank you very much. So as mentioned, we've seen 6 million plus cases throughout the world, and of those, about 6% mortality. As we drill down to cases in the US has seen about 1.8 million cases, so that's 28% of the worldwide cases, and the deaths have been about 28%. Drilling down to New York State has seen about 360,000 plus cases. That is about 6% of the worldwide cases, and that's 20% of the US cases. And the total deaths of the world have been about 8% and 28% of US mortalities. Specifically, we get to New York City, which we would consider the epicenter. You could see that the counties, how they have been impacted. Queens, with the highest burden. Kings, which is actually Brooklyn, for those who are not familiar with that term. And as we go down, Bronx. So Queens, Brooklyn, and Bronx were the highest hit. So we saw 200,000 cases, which represents 3% of the worldwide cases. That's 11% of the US cases, and 54% of New York State cases were here in New York City. And the deaths, as you could see, we had about 72% of the New York State mortalities. Northwell Health. We should mention a little bit that Northwell Health is the largest healthcare organization in New York State. We have over 70,000 employees. We have 20 plus hospitals. And because of that, you could see when you drill down to the cases that we had, 45,000, we represented 0.7% of the worldwide cases. At some point, we were above 1% at our peak. This represents 2.5 of the US cases, and this represents 12% of the New York State cases. So a tremendous amount of patients that came through our system. The majority of the hospitals that took the burden were in Queens, as mentioned, and so Forest Hills had a tremendous impact, and LIJ, which is on the border of Queens and Long Island, also saw a significant amount of cases. So because of that, we had to, as mentioned eloquently by Brian, distribute our cases. Not one hospital could take this burden. So there were about 852 patients that were moved throughout the system. Lenox Hill took 200 plus of those patients to allow the other hospitals to function and distribute patients where there was capacity. You could see the ramp up. We saw our first patient at Lenox on March 7th going into the 8th. And the rest is history. As you could see, the amount of positive COVID cases at our peak, 57% of the patients that were tested were COVID positive. So the ED had to prepare for this. One of the things for folks who are not familiar with New York City, we often work in very tight spaces in the emergency department, and often we don't have the luxury of isolation rooms. Due to the tremendous work that our engineers did, we converted spaces that were traditionally curtain spaces into isolation rooms pretty much overnight. We also had to have additional space at our peak to be able to manage a hot and cold zone. The concept is that we would manage COVID and non-COVID patients in separate areas. Through the support of the hospital administration, we took over a PACU, which wasn't being utilized as surgeries were being suspended. PPE, as mentioned by all the presenters, was a challenge. And at the beginning, there was panic and there was fear. So we had to make a tough decision to centralize the supply and locations of our PPE and distribute them on a more organized fashion as to preserve the amount of PPE that we had. We mentioned that Lenox Hill ED had to accept transfers from Forest Hills and Valley Stream. Some of those transfers went directly to critical care units, but some of the patients became unstable during route and had to stop in the ED to be stabilized. The community support was tremendous. And in retrospect, and still to this date, I think that was very, very important. The morale for our staff at times was not optimal. This was very stressful, as everyone has witnessed. And so the community support, the clapping that occurs at 7 o'clock had tremendous value for our staff. The other thing that we had to come up with was that not all the patients needed or could be admitted, and we had to have a way to support them at home. And so we will drill down into that process. The team, beyond the physicians, also with the nurses, we had to really reorganize ourselves. In terms of the providers, we had to rearrange the schedule to increase physician coverage because there were patients that were coming in multiple at once that needed critical resuscitation. And traditionally in the overnight hours, we would tend to have less physicians because of the community we were in, but we had to rearrange that. We also had to create a sick backup call because we anticipated that some of our physicians could potentially get ill, and we needed to have coverage immediately. There is one scenario I remember where a physician actually self-reported that he had a fever while on shift, and this physician turned out to be COVID positive. And luckily, with the coverage that we anticipated, we were able to quickly take care of him and provide the coverage that the ED needed. There's a lot of collaboration with the inpatient teams for efficient sign-out and admission procedures because there was a lot of flow issues, and we had to get the patients out to the critical care units to be able to receive new patients. We also onboarded 12 traveling nurses. We repurposed 6 former ED RNs to help us with additional volume in the ED. And we really needed nurses that were critical care and emergency trained because these procedures and the things that we did were very high risk. And so we couldn't introduce nurses without the level of training of ED and critical care. We also centralized our triage process. We used to run a dual triage process, walk-in and ambulance. We made it all one. This increased our ability to efficiently communicate and distribute the patients to our hot and cold zones. Intubations, we should take some time. This was probably the single most important thing that we did as emergency medicine physicians. And in doing so, we had to protect the staff and we had to protect our patients. The PPE was critical. To the PPE, I recommended strongly that we added double gloving. And the idea behind that is that you would do your procedure with 2 gloves, and prior to, after your intubation and prior to touching anything else, you would remove that glove that was contaminated and still have a clean glove underneath you, so you wouldn't inadvertently contaminate the area around you, any equipment around you, or any staff. We limited the staff during the intubations to avoid further contamination. We avoided the use of bag valve mask. Non-invasive ventilation was not supported. And we also did not use high flow nasal cannula. Being over 6 liters was not considered. If a patient needed that level of support, we immediately intubated them using rapid sequence intubation, using rocuronium, which is a longer acting paralytic, so that the patients weren't coughing and gagging and spewing potentially contaminated virus. We also used a bacterial viral filter to minimize aerosolization. We used video laryngoscopy exclusively, almost exclusively. And as you could see, we also used a shield around the patient's head to prevent aerosolization. Capnography monitoring, which we would do sometimes with color colorimetry, we removed that and we used end-tidal monitoring. We also started to incorporate the protocols of our critical care colleagues immediately. We went to low tidal volume, and resuscitation with IV fluids was minimized to 10 millimeters, 10 cc's per kilo, versus our traditional resuscitation of septic patients with 30 cc's per kilo. As you can see, our amount of intubations increased at our peak almost 50% over what we traditionally would do. Year to date, we've seen an increase of about 30% of intubations. That was exclusively, almost exclusively, due to the amount of COVID patients that we had. We also added additional ventilators on standby in the ED. The management of COVID patients and the intubations almost became a routine for emergency medicine physicians. And there was a sense that they felt that they wanted to do more. They knew that there were a lot of medications being used and a lot of protocols being followed in the critical care unit. And so they wanted to be part of that. And one of the things that we felt that we could do to help our colleagues in critical care make faster decisions was to order assays that we traditionally would not order. So as an example, C-reactive protein and ferritin, we incorporated in our order set to be able to give a sense of, is this a patient that's about to run into toxic storm, a cytokine storm? And in which case, the medical team can make a quicker decision in starting IL-6 and plus or minus steroids. Also, the use of D-dimers. If we found that the patient had elevated D-dimers and were persistently hypoxic, the medical team could make earlier decisions in terms of anticoagulation, and also the use of CT scan, not only to look for evidence of COVID, but also to determine if the patient had a huge clot burden, which required potentially, as mentioned by Dr. Carpati, TPA. And procalcitonin was also added, and that could help us make better decisions and quicker decisions in terms of the potential of superimposed pneumonia on top of COVID. And at the very beginning, we also ordered G6PD to see if the patient would qualify or was safe to receive hydroxychloroquine. In terms of disposition, our admission rates traditionally are 25% of the patients who come to the ED would be admitted. During the peak of COVID, we admitted 56% of our patients. So every time 2 patients walked into our ED during peak times, 1 of the 2 would be admitted. There was a 14% inpatient mortality. The medical team did a very good job of supporting the patients. This compares to 32% mortality that was found citywide. So some of the patients that were discharged, because we couldn't manage all of the patients, we had to make some very difficult decisions. We were discharging patients with, that we traditionally would not discharge with, who were low saturations in the low to mid 90% with evidence of bilateral pneumonia. We would discharge them to home, but we had to support them. So we found a very eloquent way of supporting them through the services that were provided by care management in the system. This was centralized. This was being done throughout the other hospitals at Northwell. We sent the patients home with instructions of how to hydrate, how to support their respiratory exercises to do for their respiratory improvement. We gave them pulse oxes. And as you can see, our navigators would call the patients, and they had a dashboard. They kept metrics in terms of the patient's symptoms. And in some instances, when the patient's symptoms worsened, they were able to intervene and have the patients come to the ERs to be admitted. And I think this was a wonderful model, and probably a model that we will continue through the future for other disease entities. So switching gears, some of the disparities in healthcare have been mentioned. I think it's very important that we continue to study this. There was a lot of this information that got out in social media, that got out in newspaper print, and often this data is interpreted in ways that are not necessarily advantageous for minorities. And so a lot of the studies are really starting to drill down on more analytics to really look, why are there differences in terms of the outcomes for African Americans? So one study in California that looked at over 1,000 patients found that non-Hispanic white patients compared to African Americans had a 2.7 times higher odds of hospitalization after adjusting for age, sex, comorbidities, and income. But as mentioned, disparity figures without explanatory context could perpetuate harmful myths and misunderstandings. So a very good study that recently came out of New Orleans, Louisiana, at Hofstra, which is one of the largest healthcare organizations there, found that Black race was not necessarily associated with higher in-hospital mortality than white race after an adjustment for differences in social economics and clinical characteristics. So that's the kind of data we really need to drill down into. If we better understand that after adjusting for these things, that yes, in fact, Blacks have higher rates of diabetes, obesity, hypertension, then we could really start to drill down on those entities and try to figure out why these are happening. What is it that's happening at the home level? What is it that's happening in the community that is creating these issues? The other thing I want to mention is that shelter in place, while it had benefits, for certain socioeconomic folks, this may not have a benefit. You tell 6, 7 folks to shelter in place, and they live in a 500, 600 square foot area, this may not actually work. Where traditionally folks would go to work, come home at different times, sleep at different times. Now you tell them all to shelter in place. And that actually created issues in Queens and Brooklyn, where it wasn't one patient that came in, but it was the whole family that was afflicted. And that's what led to these numbers. So we need to better understand household crowding and conditions in the home when we make decisions to shelter in place. Switching gears, as we move forward, we have a issue. And the issue is that we have seen significant decreases in volume in the ED. This is driven by fear. Patients are now, as we're transitioning, are fearful of coming to the ED. And you could see data, it's reported, and not only in New York City, but throughout the United States and throughout the world. Specifically in the US, we've seen a 48.6% volume reduction in terms of emergency department visits. Specifically at Lenox Hill, we've seen a 20% decrease year to date in the chest pain presentation. We've seen an 18% decrease in stroke volume. And what we're seeing is that patients are dying in their homes. I wrote an opinion piece that was picked up by the Wall Street Journal about this very public health dilemma that we're facing here. And we wanted to get the message out that it is deadly to fear the emergency room. In this publication, we noted that there are 5,000 plus excess deaths that are non-attributable necessarily to COVID that we saw during the pandemic of COVID at its peak. This is a letter that we got from a patient who was fearful of coming to our emergency department after suffering from abdominal pain. We were able to convince him to come to our emergency department. He had a great experience. We diagnosed his appendicitis early. We were able to intervene with IV antibiotics and send him home with PO antibiotics, which is a change. COVID has made us consider how we manage patients, and this is something that may have lasting effects for us, where in the past, maybe we would have taken this patient for laparoscopic surgery. We managed him successfully as an outpatient. The patient was very thankful and continues to be thankful for this. So the message we need to get out to the patients are that the emergency departments are safe, and these are the interventions that we're taking. We're managing the departments with hot and cold zones. We're segregating patients with potential COVID for patients who do not have any risk factors or are not known to be COVID positive. We're getting messaging out that we're taking temperatures of and screening visitors and patients as they come in, and we're screening the staff. We're creating these respiratory symptom-free zones, as mentioned. With the use of protective equipment, we're publicizing how we're doing that so that the public knows that the environment is safe. We're masking everyone that comes in, both the providers and the patients. And I think that is here to stay. And we're minimizing the visitors that are coming in. We're putting on the bed as the patient comes, they'll see a visual. It says squeaky clean. Just as they do in the hotels, they'll know that the environment that they're taking up, the space that they're taking up, has been cleaned and sanitized. We thank you. We thank you for your support. We thank you, the community at large that has supported the emergency departments. And we still have work to do, but we will get through this together.
Thank you,
Yves. Dr. Ortiz.
Tremendous presentation. As always, very clear educational talk on what you went through. I've been reading, even though we're a little bit over time, I've been reading here about some of the questions in the chat. And specifically, there has been a back and forth about a specific question that said that the creation of an urban epicenter in the middle of Brooklyn or anywhere else in the city, as opposed to a citywide lockdown, would have been beyond the imagination of the city leadership at the time. And that was Dr. Carpati responding to question that said, since the first death of COVID-19 was in Bushwick Wyckoff Hospital, why wasn't Bushwick made an epicenter as was New Rochelle? Could it have saved lives? Any opinions?
I think that's a very good point. I mean, it's a tough one. The density of the city makes it very challenging. The socioeconomics, there were folks who had the option to leave the city and to be in quarters that had more size and space for the inhabitants. This is really a socioeconomic issue. And also I should mention, there were disparities in terms of the care provided in certain hospitals. And these hospitals are normally, like the Wyckoff city hospitals, already are challenged. They had challenges with PPE. They had challenges in terms of crowding. They didn't have the integration that Northwell did and was able to move patients around. I personally had a loved one who passed, was in a hospital that I will not mention, but when you spoke to the providers there, they were overwhelmed. They didn't have the protocols such as proning that we had. A lot of these proning protocols that we've had them traditionally, we had them in the past, and we were able quickly to pivot and manage our COVID patients, and I think that's what made us successful. So, you know, when hospitals were already struggling, and then you add a pandemic such as COVID on top of it, it made it even more difficult for them to be able to be successful.
Okay, well, Dr. Duroseau, thanks a lot for your presentation and your time.
Thank you very much.